Muy bien, estamos en vivo. Perfecto. Bueno, muy buenas tardes a todos. Disculpas porque eran las 19 horas, unos minutitos por una cuestión técnica. Un placer estar con ustedes como presidente y en nombre de toda la comisión directiva de la Asociación Argentina de Menopausia y Andropausia, les damos la más cordial bienvenida a estas primeras jornadas virtuales internacionales de AMA. Queremos agradecerles y hacer en este acto de apertura, decir unas palabritas con la secretaria general, la doctora Dra Rodríguez, y el delegado internacional de AMA, el profesor doctor Néstor Ciceles, pero antes quiero agradecer, porque hay que empezar agradeciendo, sobre todo cuando se trata de una sociedad que tiene un año y unos meses, entonces, y que ha crecido tanto. Primero queremos agradecer a nuestros auspiciantes. Contamos con el auspicio de la Federación Argentina de Sociedades de Ginecología y Obstetricia FASGO, contamos con el auspicio de FLACIN, Federación Latinoamericana de Sociedades de Climaterio y Menopausia, ISGE, Sociedad Internacional de Endocrinología Ginecológica, EMAS, Sociedad Europea de Menopausia y Andropausia, y también contamos con el auspicio de nuestra madre, la IMS, la Sociedad Internacional de Menopausia. Así que, bueno, estamos muy felices, y también de FASGO, que somos sociedad adherente. Queremos agradecer a todos los disertantes nacionales e internacionales. Contamos con más de 30 disertantes nacionales, 32 internacionales, y todos los miembros de nuestra comisión directiva forman parte de este evento como presidentes, como secretarios, como disertantes. Agradecer a los 24 directores que dirigen comisiones de AMA, presentarán las guías, recomendaciones de AMA. Agradecer a nuestra directora de publicaciones, la doctora Débora Yankelevich, con el Info AMA mensual que le llega con las actualizaciones en menopausia y andropausia. Queremos agradecer a todos nuestros asesores nacionales e internacionales, muy particularmente a mi amiga la doctora Dra Rodríguez, que me apoya incansablemente, a mi familia, a mi esposo y a mi hija, que bueno, les quito muchas horas en esta familia hermosa que tenemos por dedicarla a la actividad societaria, y especialmente a mi hija, la futura doctora Priscila Lucino, quien ha hecho la traducción y la subtitulación de las 2 conferencias magistrales de lupo que tendremos a continuación, de la doctora Rebecca Glaser y del doctor Barry Sears. Agradecerle al doctor Adrián Gaspar, a quien lo voy a presentar en un ratito, por el contacto y por la coordinación de las futuras 2 conferencias, y especialmente a la doctora Alejandra Nigro, sin cuya colaboración tremenda no podríamos estar transmitiendo en este momento, ni haber transmitido todas las actividades científicas a lo largo de estos años, de 2020 y 2021 de AMA. Tuni, querida, para los amigos, inmensas gracias. Gracias de parte de toda la comisión directiva y particularmente de mi parte. A la doctora Salas, que nos ha ayudado con los flyers, a todos. Y bueno, ahora quiero presentar a mi amigo, el profesor doctor Néstor Ciceles, padre del climaterio en Argentina y en Latinoamérica, y fue el presidente del Congreso Mundial de Menopausia de la IMS en el año 2005, y tuve el honor de formar parte de ese comité organizador. Querido Néstor, te dejamos para que digas unas palabras, y después nuestra amiga Eli también va a decir unas palabras. Néstor, te escuchamos.
Gracias. Buenas tardes. Para mí un gran honor dirigirles la palabra en este acto de apertura de las primeras jornadas de la Asociación Argentina de Menopausia y Andropausia. Quiero felicitar específicamente a la profesora Mónica Ñáñez, que después de haber presidido exitosamente la Asociación Argentina para el Estudio del Climaterio, decidiera crear la Asociación Argentina de Menopausia y Andropausia, con el mismo espíritu científico, multi e interdisciplinario, con un enfoque integral y actualizado de la problemática, en este caso, no solo de la mujer que envejece, sino también del hombre, atentos a no perder la preciosa ventana de oportunidad para implementar medidas de prevención que eviten el rápido deterioro tanto físico como psíquico. Ha tenido la gentileza, como lo ha comentado, de nombrarme delegado internacional, y estas primeras jornadas son un ejemplo que en armonía pudimos lograr que muchas de las personalidades más relevantes en el campo de la endocrinología ginecológica y del climaterio estuviesen presentes, esta vez de manera virtual. Los relatos de los especialistas convocados abordaron la temática de la menopausia y de la andropausia, y en especial fueron discutidos aquellos conceptos que generan más controversias. Poniéndole sabor a mi Buenos Aires querido, diré que en la vida, como en el tango, mientras uno avanza, el otro retrocede. Y en lo nuestro, para seguir este ritmo, debemos lograr que mientras la ciencia avance, los mitos retrocedan. Nuevamente, gracias Mónica por considerarme e invitarme a decir estas reflexiones en este acto de apertura.
Muchísimas gracias, emocionantes tus palabras, querido amigo, sos el padre del climaterio de Argentina y de Latinoamérica. Muchas gracias, un honor que seas nuestro delegado internacional. Querida amiga Elida Rodríguez, secretaria general, vas a decir unas palabritas para después ya ir a las conferencias, amiga.
¿Qué decir? Feliz y emocionada. Feliz porque realmente la repercusión de hoy fue algo inimaginable. Toda Argentina, toda Latinoamérica, Europa, Estados Unidos, realmente no esperábamos tanto. Gracias, gracias, gracias a todos los presentes. Y emocionada, ¿por qué? Porque estoy con dos grandes amigos. Quiero hacer un saludo a toda la comisión directiva, a los directores, pero especialmente a ustedes dos que son mi maestro, Néstor, mi formador, como tantos de tantos. Allá pasé muchos años en la Universidad Favaloro, me formé contigo en climaterio y seguí tus pasos. Bueno, y acá nos encontramos siendo compañeros, no me lo imaginaba en la vida. Gracias, Néstor. ¿Qué decir de vos, Mónica? Estoy muy emocionada, no pensaba tanto. Gracias por tantas satisfacciones, gracias por darme tanto lugar, y dijo Eva 40, que sos muy, muy generosa. Y la verdad es cierto. ¿Qué más decir de tu currículum, del currículum de ambos? Son maravillosos. Sigamos juntos, que AMA es una familia. AMA es inclusiva, AMA es argentina, AMA es federal, AMA es de Latinoamérica, AMA no tiene fronteras. AMA abraza a todos con cariño para seguir creciendo. Gracias.
Muchas gracias, Eli. Bueno, quiero agradecer a nuestros sponsors, por último, sin cuya colaboración por ahí estos eventos son medios imposibles. Agradecer al laboratorio Baliarda, agradecer al laboratorio Bayer, Beta, Megalabs, VIP Farmacia y Astatec Láser. Así que bueno, muchísimas gracias, seguramente mucha gente quedará en el tintero, pero muchas gracias, gracias, gracias y gracias a todos ustedes, queridos colegas, por acompañarnos sábado tras sábado en nuestras actividades científicas, en el curso online del año pasado y en el posgrado de este año. Así que bueno, queridos amigos, un placer, y ahora convoco al doctor Adrián Gaspar, mi querido amigo, y a la doctora Rebecca Glaser, porque vamos a tener la primera charla. Hola Adrián, ¿cómo estás? ¿Cómo te va?
Hola Mónica.
¿Cómo estás?
Buenas noches para mí, buenas tardes para ustedes.
Sí, vos estás... Bueno, Adrián es un médico argentino, mendocino, te voy a presentar, que vive ahora en Estados Unidos, pero en este momento está dictando un curso en Italia, en Florencia, y después se va a Pisa. O sea que bueno, así, de un lado para el otro, y llegó hoy, viajó del avión. Así que bueno, Adrián, te voy a presentar, tengo el honor de presentarte. En primer lugar, bueno, Adrián es médico ginecólogo, hace longevidad saludable, que todos deberíamos aprender, hace cosmetoginecología, pero Adrián fue el pionero del láser en el rejuvenecimiento. En realidad no queda mal decir rejuvenecimiento hoy en día, sino en las técnicas regenerativas para la atrofia urogenital o síndrome genitourinario de la menopausia. Adrián presentó un trabajo en el año 2011 y a partir de ahí comenzó la cátedra de trabajos de láser en ginecología vulvovaginal y específicamente en la atrofia urogenital. Es un antes y un después de Adrián Gaspar en toda la bibliografía. Premiado, multipremiado por distintos lugares, en distintas sociedades, expresidente de la Sociedad Latinoamericana de Ginecología Estética y Funcional, bueno, y además pionero ahora en el láser intrauretral, del cual nos habló esta tarde. Así que bueno, Adrián, muchas cosas más en honor al tiempo y decir lo más importante, que sos el director de la Comisión de Técnicas Regenerativas de la Asociación Argentina de Menopausia y Andropausia, y que gracias a vos y a tu contacto con la doctora Rebecca Glaser, que ya nos está escuchando y está preparada, vamos a tener el honor de escucharla a ella y a Barry Sears. Bueno, te escucho para que la presentes a tu amiga, la doctora Rebecca Glaser.
Muchas gracias, Mónica. Es un gran honor. It's a great pleasure for me having been given the opportunity to present Rebecca Glaser. Dr. Rebecca Glaser es una referente mundial indiscutida en el manejo del bienestar y la calidad de vida de las pacientes con pellet implantes de testosterona. Ella ha dedicado su carrera a la mastología, a la cirugía del cáncer de mama, pero en los últimos años abandonó la cirugía y se dedicó al bienestar de las mujeres. Ha publicado y tratado innumerables cantidades de casos. Más de 1.500 pacientes sobrevivientes de cáncer de mama han mejorado su calidad de vida con esta técnica. Ha sido citada en más de 2.000 publicaciones indexadas de todos sus trabajos. Lidera ahora también research en el área de implante de testosterona con inhibidores de aromatase. So Rebecca, it's a great pleasure for me having you here. Thank you so much for being with us. So now we can start with your presentation. La presentación de la doctora está subtitulada, está grabada, así que estamos esperando que la podamos ver.
I would like to thank Dr. Adrian Gasper
¿Se escucha?
No, falta el play.
for inviting me to speak at this event. The title of my presentation is Testosterone Implant Therapy in Men and Women, Health, Wellness, and Disease Prevention. I would also like to thank TrocarKit.com for sponsoring this webinar. There are resources available at TrocarKit.com. These include publications, multiple presentations, handouts which you can use in your practice, sample consents, and videos of the insertion procedure. Much of the rationale supporting this presentation can be found in our recent article, Testosterone Implant Therapy in Women with and Without Breast Cancer. There are many abbreviations used throughout this presentation. Testosterone, testosterone deficiency, estradiol, androgen receptor, estrogen receptor, breast cancer, and aromatase inhibitor. I am going to discuss the importance of testosterone in health and wellness. We will also cover androgen decline, aging, and disease. I will also focus on testosterone and breast cancer, and testosterone replacement with pellet implants and levels on therapy. In order to optimally treat patients, it's important for you to understand the critical role of testosterone in health and disease prevention. In this talk, we're going to discuss the location of the androgen receptors, the function of testosterone at those androgen receptors. We will also discuss the role of aromatase and symptoms and diseases associated with aging that improve on testosterone therapy. Testosterone is the most abundant biologically active hormone in both sexes. It is produced in the ovaries, the testicles, the adrenal gland, and locally at the cellular level from androgen precursors. Testosterone has a direct effect at the androgen receptor. It is also a precursor for DHT and estradiol, where it has an effect at the estrogen receptor. Interestingly, the androgen receptor gene is located on the X chromosome. This is a very misleading chart, showing fluctuating hormones during the menstrual cycle. However, testosterone levels are not lower than estradiol levels. In fact, testosterone levels are greater than estradiol levels throughout the entire female lifespan. The adrenal androgens are also a major source of testosterone locally in the tissues. Question: do men or women produce more DHEA and/or androstenedione, the direct precursor to testosterone? Interestingly, men and women produce approximately equal amounts of the androgen precursors. The androgen precursors are a significant source of bioavailable testosterone at the androgen receptor. In women, serum testosterone accounts for only 10 to 20% of bioavailable testosterone. DHEA and androstenedione account for over 80% of bioavailable testosterone. This fact will become more important when we talk about hormone replacement therapy with testosterone. In men, 50% of bioavailable testosterone is from serum testosterone and about 50% from the adrenal precursors. Adequate levels of androgens are important for health, well-being, and disease prevention in both sexes. Understanding this will help you recognize the indications for testosterone therapy. Everyone is aware of testosterone's profound effect on lean muscle mass, as well as testosterone's effect on strength, coordination, and confidence. Adequate levels of testosterone are also important for sex drive and sexual performance. However, testosterone's benefits go well beyond sex drive and libido. Androgen receptors are located in every organ system in both sexes. Testosterone has a function at those androgen receptors. Testosterone has an indirect function at the estrogen receptor. Testosterone is the direct precursor for estradiol in every major organ system, including the gonads, in both sexes. Adequate amounts of testosterone are necessary to make adequate amounts of estradiol. We are going to review the function of testosterone at the androgen receptor in various organ systems throughout the body. Testosterone is critical for immune function. There are androgen receptors located on neutrophils, mast cells, macrophages, T cells, B cells, and lymphocytes. Testosterone's role is to decrease inflammation, decrease inflammatory cytokines, and it is involved in T cell homeostasis. Remember, all organ systems and diseases are affected by inflammation. Androgen receptors are located in the brain and nervous system. Testosterone is neuroprotective. It's involved with spatial cognition and focus, verbal learning, and memory. Testosterone has been shown to reduce depression and apathy. It is also a mood stabilizer. It helps prevent anxiety and instill self-confidence. We have demonstrated that 90% of women with sleep disorders and insomnia improve on testosterone implant therapy. This is a sleep pattern of one of my patients. The picture on the left is at the end of testosterone therapy prior to reimplantation. The patient had become symptomatic, and you can see the amount of restless sleep in blue and the amount of awake time in red. On the other side, on the right-hand side, is after receiving her testosterone implant therapy. Note the complete or almost complete resolution of restless sleep. Testosterone also helps regulate beta amyloid. It is an immunomodulator and reduces inflammation, not only in the brain and nervous system, but throughout the body. It has a beneficial role in Parkinson's disease. In fact, the very first patient I treated was a patient with Parkinson's disease. Following testosterone pellet implants, his quality of life significantly improved, as well as his tremor and other symptoms. Testosterone has also been shown to be beneficial in Alzheimer's disease, dementia, and memory loss. Testosterone also has a beneficial effect on essential tremors. This is a signature of a female patient with essential tremors. The signature on the top is prior to receiving testosterone pellet implants. The signature below is 2 hours following her first testosterone pellet implant. Within 24 hours, this same patient was able to drink from a water bottle without a straw. She was able to drink liquids from a cup. 2 days after her first testosterone implant, she was able to eat soup at a restaurant for the first time in 5 years. She can now get money out of the ATM machine on the first try by hitting the numbers correctly. Most importantly, she was able to blow dry her hair much better. Testosterone also has a therapeutic role in multiple sclerosis, peripheral neuropathy, chronic pain, and fibromyalgia. It can improve migraine headaches. In fact, we showed that over 90% of women with migraine headaches improved on subcutaneous testosterone. Low testosterone and high estradiol in men may be associated with migraine headaches. The cardiovascular system. Testosterone is a vasodilator. It augments cardiac output. Testosterone strengthens cardiac muscle and inhibits plaque development. It also modulates cardiac adaptive hypertrophy. Testosterone also has an angiogenic effect. Testosterone reduces arterial stiffness. It improves oxygen consumption, increases functional exercise capacity, and has a therapeutic benefit in congestive heart failure in both sexes. Testosterone also inhibits platelet aggregation. And we demonstrated a reduced incidence of venous thrombosis in male patients treated with testosterone pellet therapy. The cardiovascular benefits of testosterone have been recognized for over 40 years. Testosterone treatment of cardiovascular diseases is a brilliant paper published by Jens Moeller in 1984. They talk about the therapy of cardiovascular disease using testosterone treatment. They also discuss the role of testosterone in preventing diabetes and preventing amputations due to diabetes. I highly recommend reading this. There are androgen receptors in the pulmonary system, in the lungs, the trachea, and the bronchi. The androgen receptors are located on both mesenchymal and epithelial cells. Testosterone acts as a bronchodilator. It improves asthma. It also acts as a pulmonary vasodilator. Again, it is anti-inflammatory, which greatly impacts pulmonary disease. Testosterone also depresses sensitivity to histamine substances. There are also androgen receptors throughout the gastrointestinal tract, liver, pancreas, and kidneys. Testosterone improves glycemic control. It increases glucose tolerance, enhances glucose-stimulated insulin secretion, and increases insulin sensitivity. Testosterone stimulates peristalsis. It also stimulates erythropoietin. Testosterone induces alcohol dehydrogenase, and it suppresses the development of steatosis, virus-related hepatitis, and cirrhosis. There are also androgen receptors in the uterus, vagina, and bladder. Testosterone strengthens the bladder. It improves incontinence and urgency. It also has a positive effect on the vaginal blood flow. It improves vaginal strength and lubrication. Testosterone, when it fits in the androgen receptor, prevents proliferation of the uterine lining. It has been used for therapy for endometriosis, dysfunctional uterine bleeding, and uterine fibroids. We have several patients in clinical practice who have complete resolution of lichen sclerosus on subcutaneous testosterone implant therapy.
There are androgen receptors in the muscles, joints, and synovium. Testosterone increases lean muscle mass and strength. It is anti-inflammatory. It relieves pain. It regulates dendritic morphology and growth in motor neurons. Testosterone has been shown to be an effective therapy for rheumatoid arthritis and other autoimmune diseases. It has also been used as treatment for sarcopenia.
There are also androgen receptors in the breast and mammary gland. Testosterone inhibits proliferation and hyperplasia of the breast tissue. It also decreases estrogen receptor alpha, which is important. When estradiol fits into the estrogen receptor alpha, it stimulates breast tissue. It also increases estrogen receptor beta, which is beneficial in the breast tissue. Testosterone is pro-apoptotic and inhibits breast cancer growth. In 2019, we published the results of our 10-year prospective cohort study, which showed a reduced incidence of invasive breast cancer in women treated with testosterone pellet implants. Testosterone, including testosterone pellet implants, have been used to treat invasive breast cancer since 1937. Testosterone increases cancer cell death. It decreases invasive breast cancer growth. However, testosterone can aromatize to estradiol and stimulate breast cancer tumor growth via the estrogen receptor. The critical role of aromatase, location and function. Remember, testosterone is aromatized to estradiol in every major organ system in both men and women. Similar to androgen receptors and estrogen receptors, aromatase is located in every major organ system in both sexes. The peripheral conversion or aromatization of testosterone is the major source of estrogen in men and postmenopausal women. This estrogen may not be reflected in serum levels.
Certain conditions can increase aromatase activity, resulting in the production of excess estradiol. One of these is obesity. Fatty tissue contains an abundance of the enzyme aromatase. Certain medications increase aromatase activity. Disease states such as benign prostatic hypertrophy, endometriosis, and uterine fibroids often have increased aromatase activity. This can be problematic as the excess estrogen can worsen these conditions. The same is true for certain cancers, including prostate, breast, and endometrial cancers. They produce their own aromatase, increasing local estrogen formation and possibly worsening the disease. Symptoms of excess estrogen include the development of breast tissue and gynecomastia, fluid retention, weight gain, anxiety, emotional disturbances, irritability, aggression, erectile dysfunction, and lack of effect from endogenous testosterone or testosterone therapy. Androgen decline. Clinical effects, aging. Androgens decline with age in both men and women. There is a marked decline of testosterone between the ages of 20 and 50 to 60. Symptoms of androgen deficiency in women often begin prior to menopause. In fact, 1/3 of the patients we reported on were premenopausal. Androstenedione, the direct precursor to testosterone, also declines markedly with age in both sexes. Remember, men and women have similar levels of androstenedione. Similarly, DHEA and DHEAS, the prohormones, both decline with age. This significantly impacts the amount of bioavailable testosterone at the cellular level in both men and women. All androgens decline with age in both sexes. Again, note the similarity in the decline between men and women. In addition, there may be a loss of sensitivity at the androgen receptor to testosterone, further compromising the function of testosterone. The decline of all androgens, along with the age-related loss of sensitivity, explains why serum testosterone levels may not correlate with symptoms. Though laboratory assays can support a diagnosis of androgen deficiency in men, and I also agree in women, they should not be used to exclude it. It is suggested that there needs to be greater reliance on the history and clinical features, together with careful evaluation of the symptomatology and, where necessary, a therapeutic trial of androgen treatment given. This is a really important point because many guideline recommendations place too much emphasis on a single or possibly two testosterone levels. That does not make sense clinically. Serum testosterone is not a valid marker of androgenic activity in women. Again, the major source of androgenic activity is the intracrine production of testosterone from adrenal precursors, not serum testosterone. Remember, only 10 to 20% of bioavailable testosterone at the cellular level is from serum testosterone. It is not surprising that despite long series of prospective and case control cohort studies performed during the last 30 years, a correlation between serum testosterone and any clinical condition believed to be under androgenic control in women has remained elusive. Make sure you understand this concept. Symptoms of androgen deficiency and aging in both men and pre- and postmenopausal women include physical fatigue, exhaustion, bone loss, muscle wasting, fat accumulation, thin, dry skin, wrinkles, brittle hair and nails. It also encompasses chronic pain, muscle aches, and stiffness. We have previously discussed the role of testosterone as an immunomodulator. Testosterone is anti-inflammatory. With the decline of bioavailable testosterone, there is an increase in inflammation throughout the body, affecting multiple organ systems. The decline of testosterone also affects the bladder. There's an increase in urinary incontinence, frequency, and urgency. Symptoms of androgen deficiency and aging also include the development of benign prostatic hypertrophy, vaginal atrophy, decreased sex drive and libido, impotence, and a decreased sexual response. Other symptoms of androgen deficiency include dysphoric mood, depression, anxiety, irritability, loss of confidence, sleep disturbances, insomnia, vasomotor instability, and hot flashes. There are also cognitive changes and decreased mental focus and memory loss. There are many controversies surrounding testosterone therapy, particularly in female patients.
In my clinical practice, I treat most all women with testosterone implant therapy alone. I disagree that hormone therapy should equal estrogen therapy in women.
If you review basic physiology in both sexes, I suggest that hormone therapy in women should also be primarily testosterone therapy. Remember, testosterone is a major substrate for estradiol. When you provide enough testosterone to the end organ androgen receptor, there will be enough estradiol made.
This may not be the way you're used to thinking. However, adequate levels of continuous testosterone provided by the pellet implant provide adequate levels of estradiol locally at the estrogen receptor. We designed a study to measure the beneficial effects of continuous testosterone therapy alone delivered by subcutaneous implant and the relief of somatic, psychological, and urogenital symptoms in both pre- and postmenopausal patients using the validated health-related quality of life menopause rating scale. 300 women were analyzed. 36% of patients were premenopausal and 64% were postmenopausal. We looked at hot flashes, heart discomfort, sleep problems, depressive mood, irritability, anxiety, physical and mental exhaustion, sexual symptoms, bladder problems, vaginal dryness, and joint and muscular discomfort. Premenopausal and postmenopausal women had similar baseline testosterone levels. As expected, there was no relationship between baseline testosterone levels and presenting symptoms other than sexual complaints or response to therapy. Premenopausal women reported a higher incidence of psychological complaints, including depressive mood, anxiety, and irritability, which may be contributed to by higher or fluctuating levels of estrogen relative to declining testosterone levels. Postmenopausal women reported more hot flashes, vaginal dryness, and urological symptoms, which may be contributed to by lower levels of estradiol. Testosterone alone delivered subcutaneously resulted in statistically significant improvement in all 11 menopause rating scale symptom categories. Both groups demonstrated similar improvement in the total score as well as psychological, somatic, and urogenital subscale scores. Higher doses of testosterone did correlate with greater improvement in symptoms. There were no adverse drug events reported in 285 patients treated for more than 1 year. Many guidelines state that testosterone is contraindicated in breast cancer patients. Do you believe this is true, false, or both A and B? The answer is C.
When testosterone fits into the androgen receptor, it decreases proliferation both in normal breast tissue and breast tumor cells. However, as mentioned previously, testosterone is aromatized to estradiol. And when estradiol fits into estrogen receptor alpha, it can increase proliferation and stimulate growth of tumor cells. Breast cancer tumor cells produce an overabundance of aromatase, so testosterone alone, without an aromatase inhibitor, may be contraindicated in active breast tumors.
The solution seems obvious. It's the combination of testosterone with an aromatase inhibitor. This allows delivery of testosterone to the androgen receptor at the cellular level without the conversion to estradiol, which could stimulate breast cancers. In clinical practice, I have found that the combination of testosterone with either letrozole or anastrozole in a subcutaneous implant has been extremely effective and safe. The combination testosterone and aromatase inhibitor implant provides simultaneous and continuous delivery of both active ingredients while avoiding the first pass effect in either the GI tract and liver. The combined use of testosterone with subcutaneous anastrozole provides women with the beneficial effects of testosterone without the conversion of testosterone to estradiol and estradiol's adverse effects in estrogen-dependent diseases, including hormone receptor-positive breast cancer. Subcutaneous delivery has also proven useful in patients who are unable to tolerate oral aromatase inhibitor therapy. Hopefully, in the near future, there will be a combination testosterone anastrozole implant available to treat women with metastatic breast cancer.
Menopausal symptoms can be severe in breast cancer survivors in whom estrogen is contraindicated. We presented this data at the American Society of Clinical Oncology Breast Cancer Symposium in 2014. We evaluated the efficacy of subcutaneous testosterone on menopausal symptoms in breast cancer survivors. This was a prospective IRB-approved study. It included breast cancer patients stage 0 through 4. The majority of patients were estrogen receptor positive and were treated with testosterone with subcutaneous anastrozole in the pellet and a dose of 4 to 8 milligrams. Estradiol levels were monitored.
We documented statistically significant improvement in all 11 categories of the menopause rating scale. This also confirms the direct effect of testosterone at the androgen receptor and its ability to relieve these symptoms without the conversion to estradiol.
A randomized, double-blind, placebo-controlled trial evaluating the effect of testosterone on aromatase-induced arthralgias was recently published. Patients receiving testosterone therapy did report improvements in strength, lack of energy, urinary frequency, and stress incontinence. Patients receiving subcutaneous testosterone and anastrozole implants also reported improvements in hot flashes, fatigue, mood swings, urinary incontinence, and skin appearance, tone, and texture. Although arthralgias did not improve statistically on testosterone implant therapy, the 120 milligram dose was thought to be too low. Other studies with higher dosing have shown improvement in arthralgias. In summary, there is a role for testosterone along with aromatase inhibitors in hormone receptor breast cancer survivors. We have shown an improvement in quality of life. This also confirms the direct effect of testosterone at the androgen receptor on symptoms. In our long-term study, we do see a decrease in breast cancer recurrence. Testosterone alone may be contraindicated in estrogen receptor positive patients. It should be combined with an aromatase inhibitor, and estrogen levels should be monitored. I need to mention the importance of diet in prevention of breast cancer recurrence. Low glycemic, whole food diet is critical for preventing breast cancer recurrence.
Testosterone not only helps with menopausal symptoms in breast cancer survivors, it can also help with tumor control.
This is an 82-year-old patient who presented with a palpable right breast mass and palpable right axillary lymph nodes. She was treated with testosterone in combination with anastrozole, an aromatase inhibitor. You can see her baseline mammogram on the left of the screen and the visible lymph node in the axilla. 8 weeks later, after receiving the combination of testosterone with an aromatase inhibitor, the palpable mass has markedly decreased in size and the axillary lymph node has resolved. This is the patient's mammogram at baseline and 19 weeks following the initiation of testosterone anastrozole therapy. Note the remarkable response of the tumor to testosterone therapy.
Tumor control and quality of life. This next patient is a 60-year-old female patient who presented to my office 2 years after being diagnosed with metastatic breast cancer. She was so weak she could barely walk into the office, and her husband had to help her sit in a chair. She was experiencing significant symptoms.
Her symptoms markedly improved on testosterone and aromatase inhibitor therapy. She was able to get off several medications, including Vicodin, Ativan, and Ambien.
The patient is currently thriving. She's been on testosterone and aromatase inhibitor implants for 6 years now. She's done this in combination with conventional therapy. Remember, it's not either or. Testosterone and anastrozole implants can be used in combination with conventional therapy.
In summary, there is a role for testosterone along with aromatase inhibitors in hormone receptor breast cancer survivors. We have shown an improvement in quality of life. This also confirms the direct effect of testosterone at the androgen receptor on symptoms. In our long-term study, we do see a decrease in breast cancer recurrence. Testosterone alone may be contraindicated in estrogen receptor positive patients. It should be combined with an aromatase inhibitor, and estrogen levels should be monitored. I need to mention the importance of diet in prevention of breast cancer recurrence. Low glycemic, whole food diet is critical for preventing breast cancer recurrence. The next topic, testosterone implants, dosing and levels on therapy, is one of the most controversial topics there are. We're going to discuss opinions versus evidence. Fact: testosterone's effect is dose-dependent. Low doses and levels are ineffective. Testosterone therapy, including pellet implants, have been safely used for over 70 years. Therapy should be based on clinical effect and therapeutic response, benefits versus side effects, risk. There is no evidence to support adjusting implant dosing based on a single testosterone level. Clinical decision versus labs. Hormone levels fluctuate and are unreliable. An individual patient should be treated based on his or her symptoms, response to therapy, as well as the benefits and risk of therapy. An individual's physical comfort may not be related to their absolute hormone levels. The American College of Obstetricians and Gynecologists comment on hormone level testing. Individualized testing is only indicated when a narrow therapeutic window exists for a drug or drug class. Steroid hormones do not meet these criteria and thus do not require individualized testing. There are few indications for the measurement of hormone levels to a certain success of therapy when treating a postmenopausal woman with hormones. If treatment is initiated for symptom control, subjective improvement in symptoms is the therapeutic endpoint, and there is no need to assess hormone levels. Hormone therapy should not be titrated to hormone levels.
All androgens decline with age, including testosterone and the androgen precursors. This results in a marked reduction of local bioavailable testosterone at the cellular level. The testosterone supplied by the testosterone pellet implant is not only replacing the declining serum testosterone, but also the more significant contribution of the androgen precursors. You cannot compare endogenous serum levels with where the serum levels should be on testosterone therapy. Testosterone implants in women. Pharmacologic dosing for a physiologic effect.
Pharmacologic dosing for a physiologic effect. We studied 300 female patients on subcutaneous pellet implants. We dosed the patients and measured serum levels of testosterone at week 4 and at the end when symptoms returned. On a mean dose of 133 milligrams, testosterone levels at week 4 measured around 300 nanograms per deciliter. This is 4 to 6 times above endogenous ranges. End levels, or trough levels, measured 171 nanograms per deciliter. A subset from Quest Lab measured 185 nanograms per deciliter when symptoms returned, and a free testosterone of 19 picograms per milliliter when symptoms returned. This is 2 to 4 times above the endogenous ranges. There were no adverse drug events. These trough levels confirm that testosterone levels on exogenous therapy cannot be compared to or dosed based on endogenous serum ranges. We also studied the effect of subcutaneous testosterone on the female voice. 10 women were treated with testosterone implants for over 1 year. We studied voice results at baseline, 3 months, 6 months, and 12 months. There was no adverse effect on voice from subcutaneous implants. There was no lowering or deepening of the voice. 2 of 3 patients with lower than expected fundamental frequencies actually improved on therapy. The mean testosterone level for these patients during the study was 471 nanograms per deciliter, well above endogenous ranges.
This is explained in detail in our more recent article, Testosterone Implant Therapy in Women with and Without Breast Cancer, Rationale, Experience, Evidence. We have shown that testosterone delivered by pellet implant in clinically effective doses produces testosterone levels above endogenous ranges. There have been no adverse drug events related to testosterone therapy in any of our patients.
You cannot compare apples to oranges. You cannot compare the level of testosterone on testosterone therapy to endogenous ranges.
If you are treating male patients with testosterone therapy, I highly suggest that you keep copies of the following articles in your library. The first one is Fundamental Concepts Regarding Testosterone Deficiency and Treatment, International Expert Consensus Resolutions. Number 2, Testosterone Therapy and Cardiovascular Risk, Advances and Controversies. The last article I recommend is Testosterone Therapy in Men with Testosterone Deficiency. Are the benefits and cardiovascular risk real or imagined? These are available through trocarkit.com. The following list of consensus resolutions from the Mayo Clinic proceedings from 2016 address many of the controversies surrounding the use of testosterone therapy in men. Testosterone deficiency is a well-established clinical condition. Testosterone deficiency negatively affects male sexuality, reproduction, general health, and most importantly, quality of life. Symptoms and signs of testosterone deficiency occur as a result of low levels of testosterone and may benefit from treatment regardless of whether there is an identified underlying etiology. Testosterone therapy for men with testosterone deficiency is effective, rational, and evidence-based. There is no testosterone concentration threshold, less than 300 nanograms per deciliter, for example, that reliably distinguishes those who will respond to treatment from those who will not. This last statement is very important, as many guidelines create an artificial cutoff to determine the diagnosis of testosterone deficiency. Consensus resolutions continued. There is no scientific basis for any age-specific recommendations against the use of testosterone therapy in men. Even older men benefit greatly from testosterone therapy. The evidence does not support increased risk of cardiovascular events with testosterone therapy. The evidence does not support increased risk of prostate cancer with testosterone therapy. The evidence supports a major research initiative to explore possible benefits of testosterone therapy for cardiometabolic disease, including diabetes. And recently, there have been many peer-reviewed journal articles supporting this statement.
We have also studied dosing and levels in male patients. This is part of our male study in which we looked at 344 men. The data was collected between April 2014 and April 2017. At that time, the mean testosterone dose for male patients was 1,827 milligrams. 339 out of 344 patients, or 98.5%, were treated with anastrozole combined in the testosterone implant. The mean subcutaneous anastrozole dose was 15.3, with the majority of men receiving 16 milligrams of anastrozole. The mean interval of assertion was 4.8 months. The mean testosterone level at week 4 was 1,183 nanograms per deciliter. Over 25% measured above 1,500 nanograms per deciliter. Note, we were able to maintain low estradiol levels in most all patients. Testosterone level at the end of the cycle, when symptoms returned, was 553 nanograms per deciliter. And if you note, towards the end of the cycle, despite lower levels of testosterone, estradiol levels actually increased. We have seen no adverse effects from low estradiol levels. Remember, this is because aromatization takes place at the cellular level, and estrogen will not be apparent in the serum.
Similar to women, weight affects testosterone levels on therapy. Note the difference in men with a BMI of less than 25 and a BMI of greater than 35. These are end levels when symptoms return. Remember, the male patients with a BMI less than 25 receive lower doses of testosterone. So, we see higher serum levels of testosterone with lower BMIs, despite lower weight-based dosing. Levels are mid-range when symptoms return. An informed consent is obtained on all patients receiving testosterone pellet implants. It describes the off-label use of testosterone in women. It also addresses elevated serum levels on therapy. Testosterone can stimulate the production of red blood cells, and patients are monitored for polycythemia. In the United States, testosterone is listed as a teratogen, and all female patients, premenopausal female patients, must use birth control. So what is the real risk of testosterone implants during pregnancy? There are no reports in the literature of testosterone delivered by subcutaneous implant in a daily dose released of 1 to 3 milligrams having any adverse effect on a fetus. However, 400 to 800 milligrams of danazol, a potent synthetic androgen, results in clitoromegaly and fused labia in some female fetuses. Animal studies have shown that virilization of a female fetus requires greater than 30 times normal maternal levels or above 50 to 500 times human doses. The placenta buffers hormone diffusion and is a significant source of aromatase, which metabolizes maternal testosterone to estradiol. Nevertheless, contraception should be mandated. Testosterone stimulates erythropoietin and increases red blood cell production. Hemoglobin and hematocrit should be monitored in both male and female patients. In our experience, only 4 of 667 female patients had a hemoglobin over 17, and 2 patients had hematocrit over 52%. 1 patient had a hemoglobin of 18.8 and a hematocrit of 53.4%. It was recommended that she consult with a hematologist and discontinue testosterone therapy. This was likely due to secondary factors. In the past 15 years, no female or male patient in our clinical practice has had any adverse events, cardiac or thrombotic, due to secondary polycythemia. Although some studies show an association between elevated hematocrit and thrombosis, thrombosis does not accompany most types of erythrocytosis. Secondary polycythemia from testosterone therapy or other non-medical conditions, such as high altitude, does not have the same risk of thrombotic events compared to polycythemia due to medical conditions like chronic lung disease and hypoxia, which are associated with many confounding health problems. The association between testosterone-induced erythrocytosis and venous thromboembolism remains uncertain. Polycythemia is more common in men on testosterone therapy, especially men with confounding factors like sleep apnea, smoking, and COPD. We do recommend that the men donate blood for a hemoglobin greater than 18 or hematocrit greater than 54, and or lower the dose of testosterone. The main side effects of testosterone therapy in women are cosmetic. They include increase in facial hair growth, acne, enlargement of the clitoris, and hirsutism. Some women choose to discontinue testosterone therapy, while others lower their dose. Some women prefer the effects of higher doses of testosterone and treat the cosmetic side effects. It's a patient's choice.
Summary: testosterone decline and aging.
Testosterone has a beneficial effect in physical and mental health, disease prevention, immune function, glycemic control, and reducing inflammation.
Androgen receptors are located in every major organ system in both sexes. Testosterone produces a direct physiologic effect at the androgen receptor in all major organ systems. Testosterone also produces an indirect effect via aromatization at the estrogen receptor and all major organ systems. All androgens decline with age.
The role of excess estrogen and increased aromatase activity in disease states should be investigated. The causative role of excess estrogen and the side effects of testosterone should be addressed. Aromatase inhibitor therapy should be considered when indicated.
Testosterone is critical for human development and maintaining homeostasis. The gradual decline of all androgens associated with aging is responsible for many of the adverse signs and symptoms of aging, including mental and physical deterioration. Testosterone therapy must be done with adequate doses. You must monitor the clinical effects versus the adverse events. not micromanage levels.
Decades of evidence support both the safety and efficacy of testosterone therapy in both men and women, including breast cancer patients. The values and goals of the individual patient should be paramount in decision-making. Withholding adequate doses of testosterone therapy could be detrimental to an individual's health, quality of life, and survival.
I am a 59-year-old female. I developed breast cancer, estrogen-positive breast cancer, 5 years ago, and had a double mastectomy, chemotherapy, and after everything was done, I was put on some estrogen blockers, and as a matter of fact, I had tried 5 different estrogen blockers. They kept changing me to different ones. The reason why they kept changing me is because I had the most excruciating bone pain on all of them. I got to the point where I couldn't move my wrists at all. There was so much pain in my wrists and in my lower legs. I had just severe pain. I couldn't walk, I couldn't exercise. And every time I complained to my oncologist, he would just change me to another estrogen blocker. So I finally became my own advocate and started doing some research online and found the pellets, the information on the pellets with the testosterone and the estrogen blocker combined. And I went to my oncologist 3 different times, and finally on the 3rd time he agreed to let me give it a try. He said, why not? Let's just do it. So I came up here to Dr. Glaser and had my first set of pellets, and within just a couple weeks, the bone pain was totally gone. I also had just excruciating hot flashes. I could not wear shoes. If I put a pair of shoes on, a pair of socks on, my blood pressure went up, my whole body turned red. And after about 4 weeks of being on the pellets, that was totally gone. And so for the first time in my life, since I had been diagnosed with breast cancer, I felt like a human being again. I was sleeping, had no bone pain, so I was able to start exercising again. My children both told me, I drive 2.5 hours to come see her and get my pellets, and I would fly if I had to get them. And both of my children have said they would drive me if they had to, because I was really at a point on the estrogen blockers where I didn't want to live anymore. I was just in too much pain and too unhappy. So based on that, sorry about that. I have none of that anymore. I have a Thrive for Life again. I'm able to work out. I don't have any hot flashes. I don't have any bone pain. And I have my life back. And I owe that all to her and her research.
Thank you. Muchas gracias por tu tiempo, mis amigas y amigos.
Bueno, maravillosa conferencia, doctora Rebecca Glaser, muchísimas gracias, muchas felicitaciones en el chat. Ay, muchas gracias. Espectacular, thank you very much, Rebecca. Espectacular, congratulations. Todo el mundo felicita en el chat y va a haber preguntas al final. Muchas gracias. Muchísimas gracias. Ahora Adrián Gaspar, gracias. Beca, gracias. Adrián Gaspar está por ahí, gracias.
Sí, acá estamos.
No te nos vayas.
Thank you very much, Rebecca.
Bueno,
thank you very much. It was a great presentation. And we will have now at the end of after the second lecture, we will have time to discuss a couple of questions. So if you could be very glad to stay with us.
Bueno,
sí.
Bueno, querido Adrián, muchísimas gracias. Por favor, decirle a Rebeca que todo el mundo la felicita en el chat.
Everybody say is sending a congrats to you, Rebecca, for your wonderful presentation.
Okay, y que ahora vamos a escuchar al doctor Barry Sears, y después al final de la conferencia de Barry vamos a tener preguntas para Rebeca y para Barry. Así que convocamos a la secretaria general, a nuestra flamante general, doctora Elida Rodríguez, quien preside esta conferencia. Nos vemos en un ratito y vamos a compartir la conferencia de Barry. Lo convocamos a Barry.
Dr. Barry?
Yes.
Could you please? Okay. Welcome, doctor.
Would you like the video on?
Yes, please.
All right, we have that right there.
Okay, we got you. Okay, Eli.
Bueno, sí, bueno, bienvenido a todos. Bienvenido, doctor Barry Sears. Y me toca presidir esta conferencia, segunda conferencia, un camino para vivir una vida útil prolongada. O sea, lo que buscamos en esta sociedad, una longevidad saludable para hombres y mujeres. Y tenemos el agrado de contar con la presencia del doctor Adrián Gaspar, que la va a coordinar, quien es ginecólogo, especialista en longevidad saludable, es el pionero y desarrollador de las técnicas láser para el rejuvenecimiento vaginal, es autor de múltiples publicaciones sobre este tema, y lo más importante para nosotros es que es de AMA, es nuestro director de la Comisión de Técnicas Regenerativas. Bueno, Adrián, presentás al doctor, por favor.
Bueno, muchas gracias, Eli. Sí, I'm going to introduce you, Dr. Barry, in Spanish. Tengo el honor de contar con el doctor Barry Sears de Peabody, Massachusetts. Él es una eminencia indiscutida y un líder mundial en este nuevo concepto de entender qué hay detrás de las enfermedades crónicas y degenerativas, que es un proceso inflamatorio crónico, silencioso, y que perfectamente puede ser modulado desde la base nutricional, desde la reprogramación bioquímica del sistema. Él es el autor de La Dieta de la Zona, de este libro que él propone cómo es mucho más importante y se puede estudiar qué es lo que está impidiendo la curación, más que en focalizarnos en tratar síntomas de una enfermedad. Ha publicado centenares de trabajos y pertenece, bueno, a muchas sociedades. I'm not going to say many details about Dr. Sears. Dr. Sears, welcome. We are very glad to have you here. Now is your time. Thank you.
Thank you.
Solo tenemos que colocar el video del doctor y ya comenzamos.
The title of this lecture is The Resolution Response: Enhancing the Anti-Inflammatory Actions of Testosterone. There are a number of chronic conditions associated with low testosterone levels. These include insulin resistance, diabetes, cardiovascular disease, and depression. What links all these diverse conditions is that they are all inflammatory conditions. And we also know there are many inflammatory mediators that are also increased by low testosterone. These are primarily cytokines, in particular IL-6, tumor necrosis factor, and IL-1. And we also have a wide variety of reviews that basically talk about the anti-inflammatory actions of testosterone. This recent review, published in 2019, gives a very long, involved, detailed analysis of those various anti-inflammatory effects. Why is this important? Because more than 15 years ago, the major mass market magazine in America had this as their cover story: The Secret Killer, the surprising link between inflammation, heart attacks, cancer, Alzheimer's, and other diseases. You're probably thinking, perhaps basically the key to controlling all these diseases is increasing the levels of testosterone in the body. However, that initial thought is probably erroneous, because when you deal with inflammation, you need a zone. Too little of an inflammatory response, you become a sitting target for microbes. Your physical injuries would never heal. But if your inflammatory response is too high or not sufficiently resolved or turned off, then the inflammation is not resolved and the body begins to attack itself. So what you need is now a zone of inflammation for optimal health. Not too high, but not too low. Inflammation is incredibly complex. So let's use this slide to simplify it. Think of inflammation as causing damage. Think of resolution as causing healing. The question is, if inflammation causes damage, what controls healing? The answer is the resolution response. The resolution response is an ancient and evolutionarily conserved response buried deep in our DNA that turns off inflammation. But it's always linked to inflammation. What causes inflammation is an injury, and there are many sorts of injuries to our body. But whatever that injury might be, it induces an acute inflammatory response. In this phase, eicosanoids and cytokines dramatically increase. But that increase in acute inflammation then starts the resolution response, a much more complex orchestration of molecular events, composed of the reduction of inflammation, the resolution of inflammation, and the repair of the damage caused by inflammation. Only if all three of those events are now orchestrated and working correctly will you get healing. The resolution response is one that really controls our healing process. But healing requires an on-demand resolution response to any type of injury-induced inflammation. As I said earlier, it's an orchestrated series of both hormonal and genetic actions needed for success. However, each step of the resolution response can be blocked by poor dietary choices. And there are defined molecular players in the resolution response. There are hormones such as eicosanoids and resolvins. Eicosanoids are hormones that turn on and drive inflammation. Resolvins are the hormones that turn off or resolve inflammation. There are also genetic transcription factors, such as nuclear factor kappa B, that turns on the inflammatory response in every cell in your body, and also AMPK that turns off those same inflammatory responses. These four components are in a dynamic balance. In a case of resilience, they have to be able to be flexible, switch back and forth to turn on inflammation and turn it off. That's why I use a gyroscope as an indicator to indicate the necessary balance if we are to maintain healing in our body. The question of what happens, what if that balance is disturbed? What if the resolution response is blocked? And then you have some real problems, because now unresolved inflammation can become permanent. We'll have an injury, and that induces acute inflammation. But if the resolution response is blocked, so is healing. So what happens to that initial acute inflammation? It becomes somewhat attenuated to become chronic, long-term, unresolved inflammation. And this doesn't simply disappear from the body. It can become immortalized in your body, either in terms of scar tissue or fibrosis, or more insidiously, the development of cellular senescence, where normal cells are turned into immortal cells that spew out inflammation on a constant basis. So now we have a new source of inflammation that's immortalized in our body. Either one of these two consequences, fibrosis or cellular senescence, will accelerate the development of chronic disease. Therefore, to treat chronic diseases, you'll need an optimal resolution response, regardless of any type of drug intervention you're trying to use. And optimizing the resolution response requires the 3 R's. These are the reducing of diet-induced inflammation, the resolving of residual unresolved inflammation, and finally, the repairing of tissue damage caused by unresolved inflammation. If any one of these 3 steps is blocked, then basically we will not have healing and will generate new sources of inflammation throughout the body. The key dietary control points to the resolution response are listed in this slide. Each one has their own unique aspect. The zone diet, which I'll talk about shortly, its primary impact is reducing activation of nuclear factor kappa B. The omega-3 fatty acids can reduce eicosanoids, but also increase resolvents. And polyphenols, these are the chemicals that give fruits and vegetables their color. Their key action is to increase activation of AMPK. So let's talk about the zone diet first, in terms of reducing diet-induced inflammation. First of all, we have to ask what causes diet-induced inflammation. There are many mechanisms, and here are some of those. The first is excessive calorie intake. This causes inflammation in the adipose tissue and inflammation in the appetite control center in the brain. Another source of a diet-induced inflammation is the increased intake of omega-6 fatty acids, because these are the building blocks of eicosanoids, very powerful pro-inflammatory hormones. Yet another factor is the intake of saturated fats, because these can activate nuclear factor kappa B via toll-like receptors. There are also glycosylated proteins that can also activate nuclear factor kappa B via a different type of receptors known as RAGE receptors. And finally, there is called metabolic endotoxemia, commonly referred to as a leaky gut. In this situation, now microbial fragments can enter the blood and activate nuclear factor kappa B via toll-like receptors. So you can see that there's many sources in our diet that can induce inflammation every time we consume food. And that's why the zone diet was developed many years ago, not as a weight loss program, but as an anti-inflammatory diet to control and reduce inflammation. But the zone diet is also highly defined. It's calorie restricted, but one without hunger or fatigue. And the reason is because it's adequate in protein, moderate and low glycemic load carbohydrates, low in fat, but rich in fermentable fiber. As I said, the zone diet is highly defined. About 40% of the calories come from low glycemic load carbohydrates. These are primarily non-starchy vegetables and fruits. 30% of the calories are coming from low-fat protein. Another 30% coming from fat, but primarily monounsaturated fat, but low in omega-6 and saturated fats. But the one thing most people have never understood about the zone diet, it's also a calorie-restricted diet, that you're consuming between 1,200 and 1,500 calories per day. Now, that percentage of calories is often deceiving because we have to really look at the absolute levels of macronutrients, realizing that the zone diet is a calorie-restricted diet. So this means for the average female consuming about 1,200 calories per day, they'd be consuming about 120 grams of carbohydrate. That's a moderate carbohydrate load. For the typical male consuming 1,500 calories per day, that's about 150 grams. And likewise, the protein is also moderate, 90 grams for a female, about 110 grams for a male. This is about what average Americans and Europeans eat on a daily basis. And the fat content, it's a low-fat diet by any consideration. So we had to move away from thinking as percent of calories into asking what are the absolute number of calories being consumed on the zone diet. The key to the zone diet is hormonal balance. It's balancing the ratio of protein to the glycemic load of every meal to generate the most appropriate hormonal response. And we have a number of hormonal responses that can be generated depending on what that balance is. If one is eating a high carbohydrate diet, you're taking in excess dietary glucose, and this will lead to fat accumulation. On the other hand, if one's following a ketogenic diet, you're following a diet that's deficit in dietary glucose. Glucose is the primary source of fuel for the brain. And if the brain is not getting enough glucose, it will basically send out the hormone cortisol to break down muscle mass to make more glucose in a process known as neoglucogenesis. Now, that's almost as bad as fat accumulation because excess cortisol gives rise to increased body fat because it causes insulin resistance. It causes depression of the immune system, and it causes destruction of the memory cells in the hippocampus. So between these two extremes, hormonal extremes, lies a zone. We are trying to maintain insulin in an appropriate balance. And with that, you lose inflammatory fat. Now, the question is, do we have any data to support that contention? The data was actually generated by Harvard Medical School in 1999. They brought in overweight, obese adolescents to Harvard on 3 separate occasions. They stayed overnight, and then they were woken up each morning on their visit to basically have catheters inserted into their arms so they could do blood samples to look at hormonal changes. On each of the 3 occasions, they were given a meal of the same caloric balance, same caloric levels, about 400 calories. But the balance of protein to the glycemic load was different in each meal. In one meal, it was a high carbohydrate, high glycemic load meal, a typical meal that you might find in the typical Western diet. The second meal they were given on a separate time period was a high carbohydrate, lower glycemic load meal. And the third visit, they were given a zone meal. And you can see from this graph on the changes in the hormone insulin that very dramatic changes are seen depending on the balance of protein to carbohydrate. Those getting the high carbohydrate diets, there was a rapid rise in insulin and a rapid drop-off. Yet those same individuals, when eating a zone meal, basically the rise of insulin was not nearly as high and the drop-off was much slower. And looking at another hormone, the hormone glucagon, the changes were even more dramatic. In those eating the high carbohydrate diets, glucagon was suppressed. Those eating the zone meal, glucagon was increased. Why is this important? Because glucagon releases stored carbohydrates as a form of glycogen from the liver to stabilize blood sugar levels. And this is the key of the zone diet. It allows you to basically restrict calories without hunger or fatigue because you're stabilizing blood sugar levels. Two things from these slides. One, hormones change dramatically with a meal. Drugs cannot work this fast. Meals work incredibly fast. The second fact is that the hormonal changes of any meal will last only 5 hours, and then they come back to baseline. Now, the third part of this experiment, which is not shown on this slide, but probably the most interesting, after the 5-hour period, they removed the catheters from the arms of the children and then gave them a lunch of exactly the same meal they had for breakfast, and then brought them into a conference room with comic books, TV sets, and a buffet of any food they'd like to have. Donuts, cookies, cakes, crackers, chips, and said, if you're hungry, eat whatever you want. But every time a child basically took some of the food, the Harvard researchers were recording. And what they found was that children who had 2 zone meals back to back consumed 46% fewer calories in the next 5-hour period. Why? They simply weren't hungry. No behavioral modification programs, no exercise programs. They simply weren't hungry because they're controlling blood sugar levels. And this is one of the reasons why the zone diet was developed, to reduce insulin resistance. Remember, insulin resistance is one of the primary conditions associated with low testosterone levels. But what exactly is insulin resistance? It's the inability of insulin to transmit its signal to the interior of the cell. As a consequence, hormonal communication between outside the cell and inside the cell becomes garbled. And as a consequence, intracellular metabolism becomes disrupted. But that's a definition that doesn't give us much, something we can put our hands on. But we do know that when insulin resistance increases, a wide variety of disease states are associated with that, from obesity to diabetes to hypertension, cancer, non-alcoholic fatty liver disease, polycystic ovary syndrome, neurodegenerative diseases, depression, chronic kidney disease, and heart disease. Notice many of these diseases are exactly the same ones associated with low testosterone levels. Now, as to what causes insulin resistance, perhaps the most simple understanding, it's a blocked resolution response. So if you can unblock that resolution response, if you can optimize that resolution response, insulin resistance will go down, and all of the associated disease states that are attributed to insulin resistance will also begin to attenuate. The relationship of insulin resistance and chronic disease is highly characterized. This is just a listing of some of the articles in the national U.S. medical libraries on insulin resistance and each chronic disease. I've highlighted diabetes with almost 70,000 research articles relating increased insulin resistance to diabetes. And if you look at these number of diseases, a great number of them are the ones also associated with low testosterone levels. And this is why 10 years after I developed the guidelines for the zone diet, the Joslin Diabetes Research Center at Harvard Medical School issued their new guidelines to treat diabetes. 40% of the calories coming from low glycemic load carbohydrates, 20 to 30% low-fat protein, 30 to 40% fat, but primarily monounsaturated fat, and also 1,200 to 1,500 calories per day, virtually identical to the zone diet. And why is reducing insulin resistance important? Because insulin resistance is almost like the head of a snake. But we can actually view insulin resistance like a champagne fountain, but a one of chronic disease. That as you begin to fill up the top layer of glass with insulin resistance, it eventually fills up and spills over into the next tier. That next tier is diabetes. As that fills up, you basically now have other consequences of chronic diseases. Once you have diabetes, you are 4 times more likely to develop heart disease and twice as likely to develop Alzheimer's. And why? Because all of these conditions are associated with insulin resistance. Again, and insulin resistance is one of the primary considerations that one deals with dealing with low testosterone levels. However, the zone diet is only the first step toward healing. It is very effective in reducing diet-induced inflammation. But you still need to resolve and repair the damage caused by the inflammation. And for that, you'll need now 2 different nutrients, omega-3 fatty acids and polyphenols. Let's start first with omega-3 fatty acids and really focusing on high-dose omega-3 fatty acids, because you will need high-dose omega-3 fatty acids to resolve inflammation. We often think of inflammation as a raging fire that burns out the embers. It's a wonderful image. Unfortunately, it's simply not true. Inflammation will become attenuated, but it will not die out. It will become below the perception of pain, but causing ongoing damage to every cell in the body. And here's the time course of inflammation. whatever the initiating injury, there'll be edema, the swelling of the tissue, as immune cells move into the damaged site. These are basically primarily neutrophils and macrophages, and they're all pro-inflammatory. But somehow in that process, the macrophages are converted from pro-inflammatory immune cells into anti-inflammatory immune cells. What causes that transition are resolvins. And basically, if this transition is complete, you now basically have resolution and the body comes back to normal. So how do omega-3 fatty acids actually resolve inflammation? They do it by acting as the building blocks for a group of recently discovered hormones called resolvins. Incredibly powerful, orders of magnitude more powerful than hormones, such as steroidal hormones. But these are the hormones required to turn off inflammatory responses. But they will only can do so if you have adequate levels of omega-3 fatty acids in the blood. And how much do you need for resolution? The answer is, it depends. Let's say you're relatively healthy. You look good in a swimsuit, and you have no chronic disease. Your daily intake of omega-3 fatty acids should be about 2.5 grams per day. Now, this is not an outrageous level. Why? Because when your great-grandparents gave your parents a tablespoon of cod liver oil every day, that tablespoon of cod liver oil contained 2.5 grams of omega-3 fatty acids. Today in America, the average American consumes about 100 milligrams of omega-3 fatty acids per day, a 95% reduction of the amounts required to maintain wellness. But what if you're inflamed? That is, you're obese. You have diabetes or heart disease. The levels you need are greater. And what if you now have chronic pain? It's no longer silent inflammation, but screaming pain, such as you might find from rheumatoid arthritis, or basically for those with cancer. The amount required is even higher. And what if now the inflammation is inside the central nervous system to treat neurological disease? The levels are still higher. Make no mistake, these are high levels, but they're also therapeutic levels. To get a therapeutic effect, you need to take a therapeutic dose. And what your goal is to achieve is balance again. It's balancing omega-6 fatty acids in the blood to omega-3 fatty acids. Primarily one particular omega-6 fatty acid called arachidonic acid. This is the building block of all of the pro-inflammatory eicosanoids. But you need some, but not too much. It has to be balanced by the omega-3 fatty acid called EPA, which is the building block of many other resolvins. It's the balance of these two fatty acids that's key to controlling inflammation and resolution. Now, do you guess what that level is? You really shouldn't, but you can test for it. A single drop of blood can tell you what your balance of arachidonic acid to EPA is. An ideal target range is between 1.5 and 3. However, as that ratio increases, your levels of inflammation control decrease. And when that ratio becomes greater than 15, you have exceptionally poor inflammatory control. For comparison, the average American has a ratio of arachidonic acid to EPA greater than 20. That's why we're the most inflamed country in the world today, because we are suffering the most from diet-induced inflammation. And you're fortunate in Argentina that there are laboratories that can do this testing to give you a precise insight to what the ratio of arachidonic acid to EPA is, and tells you how much omega-3 fatty acids you need to give your patient to bring them into that target zone consistent with increased resolution of inflammation. Now, the first use of omega-3 fatty acids to reduce cytokines was reported more than 30 years ago in the New England Journal of Medicine. Remember, one of the other consequences of low levels of testosterone are high levels of cytokines, because they are the inflammatory mediators that cause much of the damage. In this particular study, done more than 30 years ago, they took normal individuals. They were not ill, they're not overweight, and they gave them 5 grams a day of omega-3 fatty acids. But you can see from this slide, before they even started the experiment, their ratio of arachidonic acid EPA was already highly elevated 30 years ago in America. And giving 5 grams a day of omega-3 fatty acids, the ratio dropped by nearly 90% into that target range we discussed previously. But once they stopped giving the omega-3 fatty acids, the levels of arachidonic acid EPA went right back up to their high normal levels. The importance of this is shown on the next slide. Because what these investigators at Harvard did, they demonstrated that as the ratio of arachidonic acid EPA dropped, so did the levels of cytokines, especially the cytokines which are associated with low testosterone levels. And once they stopped giving the omega-3 fatty acids, the levels of those cytokines went right back up to their baseline levels. So we already had indications 30 years ago that we had a very, very powerful dietary approach to reducing cytokine levels, keeping in mind that biological drugs, monoclonal antibodies to reduce cytokines, their worldwide sales in 2019 were $46 billion. Another recent study showed similar results in elderly obese individuals. These are people who by nature of their age and their obesity already have high levels of cytokines. And what they demonstrated in this study was by giving, again, high dose omega-3 fatty acids, within a very short period of time, you can see a dramatic drop in the ratio of arachidonic acid to EPA, and that maintained itself over the next 4 weeks. But when they looked at the cytokines, the ones which are associated with low testosterone levels, what they could see that within 4 weeks, there was a statistically significant reduction in their levels, and by week 8, the reduction was even greater. So demonstrating that the longer you maintain omega-3 fatty acid supplementation, maintain it within that zone we spoke of, the more and more cytokines are reduced throughout the body. And finally, we'll come to the last part of our dietary interventions, high-dose polyphenols. I said earlier, these are the chemicals that give fruits and vegetables their color. But now they do more than that. They're activators of AMPK, the master regulator of our metabolism. AMPK occupies a central part of every cell in the body. This slide only shows a very small sliver of all the actions that AMPK does once it's activated. But most importantly, it can reduce the levels of cytokines and eicosanoids and also activate our immune system, but only if it's activated. But when it's not activated, as you have in the situation of insulin resistance, then all these actions are basically distorted. Now, that's a complex slide, so let's make it simpler. AMPK, if activated, repairs damaged tissue. If you can repair damaged tissue, you live longer. Now, how AMPK gets activated by polyphenols is a little more complex. Polyphenols do not activate AMPK directly, but they do interact with a group of enzymes known as sirtuins. Sirtuins now work through other mediators such as LKB1 to activate AMPK, which then basically salvages NAD to reactivate sirtuins to keep the cycle going. So as long as the cycle is basically being charged by polyphenols, we have a unique mechanism, a dietary mechanism, to keep AMPK activated on a continual basis. And that's why we have many pathways of activating AMPK. The polyphenols are one way of activating AMPK. It's a good way, but not the only way. The omega-3 fatty acids are so critical in resolving inflammation, also activate AMPK, and so does the zone diet, because it's a calorie-restricted diet. Any one of these three dietary interventions will activate AMPK. But when all three are being used together as a team, you have a very powerful way to activate the master switch of our metabolism and basically to control our future in terms of our future wellness and health span. But just as there are dietary activators of AMPK, there are dietary inhibitors of AMPK. First and foremost is excess calories. The more calories you take in, the more you inhibit AMPK. How do you know if you're taking in too many calories? You have excess body fat. And this is why, as we have epidemics worldwide of obesity, we are really having an epidemic of a worldwide inhibition of AMPK. Another dietary inhibitor of AMPK is taking in too much glucose. That too will inactivate AMPK. So we have dietary activators and dietary inhibitors of AMPK. How we use them will have a great role to play of how well we maintain our status through our life. Because our goal is really to basically have the body to heal. This requires an integrated dietary approach. We've talked about the zone diet, omega-3 fatty acids, and polyphenols. But it's only when they're all working together that you enter to what I call the zone. The zone is not some mystical place. It's a real place in your body determined by the blood. It says when you're in the zone, then you know that AMPK is activated in each of your cells throughout the body. But how to get there requires a roadmap. It's not intuitively obvious. And that's why we use the blood. The blood will tell you how to basically alter your diet to get into the zone. Three markers that we use is the ratio of triglycerides to HDL. This is a good marker of insulin resistance, especially in the liver. The ratio of arachidonic acid to EPA will give you an indication of levels of cellular inflammation throughout the body. And the marker known as glycosylated hemoglobin tells you whether or not AMPK is activated. And with these three markers, what are you looking for? You're looking for a ratio of the triglycerides to HDL to be less than 1. That means your insulin resistance is low. You want to maintain your ratio of arachidonic acid to EPA between 1.5 and 3. This means you will have sufficient levels of omega-3 fatty acids to generate resolvents. And if your AMPK is between 4.9 and 5.1%, you know that AMPK is not being inhibited. So we have blood markers and defined ranges of blood markers that will tell us whether or not you're in the zone. Because these become your navigational markers, your navigational gauges to say what your future health will be. No different than trying to land in an airplane. You have to use the gauges. If they're in the right ranges, you'll land safely. If not, you're more than likely to crash. And how long does it take to reach the zone? Starting from scratch, it might take about 3 to 6 months to reach the zone as determined by the blood markers with the correct nutritional program. Unfortunately, it takes less than 2 weeks to leave the zone, which means if you want a longer lifespan, you want to stay in the zone as long as possible, ideally for the rest of your life. And this gives, I believe, a new vision for medicine, understanding how dietary control will be key to healing of any inflammatory condition, including low testosterone. Because optimal healing requires an integrated dietary control of both the hormonal and genetic mechanisms that control inflammation and resolution. I said this is a new vision for medicine, but perhaps it's not all that new. In many ways, it's back to the future. When Hippocrates said 2,500 years ago, let food be your medicine and let medicine be your food. And 50 years ago, Linus Pauling said, use the right nutrient at the right dose. The resolution response basically takes both of these old sayings and puts them into 21st century biotechnology. So in summary, testosterone replacement can have anti-inflammatory actions. But these anti-inflammatory actions of testosterone can be enhanced by activation of the resolution response. And when our both are working together, healing will be basically more efficacious, but it requires a totally optimal resolution response. And if you need more information, my latest book, The Resolution Zone, talks about all these factors we discussed in this lecture in great detail. I thank you very much.
Well, thank you very much, Dr. Barry, for an enlightened presentation. It was amazing. We really enjoyed.
Hola a todos. Hola, Rian.
Hola, hola.
Hola, hola. Hola, ¿cómo estás? Bueno, muchas gracias por esta excelente conferencia. Al doctor Barry Sears, muchas gracias. Y bueno, hay preguntas. Vamos a invitar a la doctora, a la profesora Ñáñez, nuestra presidente, para hacer algunas preguntitas que los concurrentes están haciendo. Mónica.
Bueno, muchas gracias, muchísimas gracias, Barry, excelente, maravilloso, todo el mundo felicita en el chat a Rebeca, a Barry. Bueno, vamos a formular algunas preguntas que la gente está haciendo, y bueno, y el querido coordinador, Adrián Gaspar, les va a hacer la traducción, nuestro querido amigo.
I'm going to be the translator of the questions.
Yes, I'm sorry. Okay, una de las preguntas es en una paciente, para la doctora Rebecca Glaser, en una paciente que no tiene cáncer de mama y que le está administrando pellets de testosterona. ¿Por cuánto tiempo?
Dr. Rebecca, for a patient who is not suffering from breast cancer and you are prescribing testosterone pellets, for how long would you continue the treatment? You have to activate your microphone, Rebecca.
Unmute.
Thank you.
Muy bueno pregunta. Forever, until the patient wants to stop. So you do not stop it. I have patients in their 90s on therapy. So as long as the benefits outweigh the risk.
I think, bueno, fue claro, dijo que no hay que parar la terapia, al menos que haya algún riesgo o alguna contraindicación que pudiera surgir, que para nada estaría indicado suspenderla porque ese es el beneficio. Thank you.
Perfecto. Y hay otra pregunta para Rebeca, otra pregunta, another one. Bueno, acá me preguntan, y en una paciente que tiene cáncer de mama, ¿por cuánto tiempo le administramos los pellets de testosterona, obviamente con el inhibidor del aromatase, ¿no? ¿Por cuánto tiempo en pacientes con cáncer de mama?
So in a woman with breast cancer, how long do you continue pellets?
Yes, you understood.
Sí.
Great.
For as long as the benefits outweigh the risk, but it also, in my practice, we see it prevents recurrent disease. So I would continue it until the patient no longer wanted it or benefited from it. But most breast cancer patients do not stop. They continue therapy. Adrian?
Que no tiene que, a menos que haya alguna complicación, que ella no recomienda pararlo, porque de eso se trata el bienestar, ¿no?
Now, with the aromatase inhibitor, do you know what I mean? Sometimes after 5 years, 5 or 10 años, I might stop the aromatase inhibitor, stop the anastrozole, if their symptoms, they have too low of estrogen symptoms, if they have low-grade disease, do you know what I mean? And they're 5 or 10 years out, you can treat with testosterone alone. Solamente testosterone. 5 y 10 años.
Que después de, claro, de 5 o 6 años, ella, de un determinado tiempo, ella ya puede retirar el inhibidor de la aromatasa y mantener la testosterona.
But not for metastatic disease, not for advanced disease, but stage
no para
1.
casos avanzados, sino para estadio 1.
Okay. Thank you very much. Muchas gracias, muchas gracias. Eli, vos tenés una pregunta para Rebeca también, me parece.
Sí, hay una pregunta para el público, para la doctora Glaser. ¿Hay alguna experiencia en pacientes hormonizadas trans? ¿Algún cambio con respecto a la dosificación?
One question for the audience is about if there is any recommendation for those transsexual patients in terms of dosification.
I don't treat a lot of transsexuals, do you know what I mean? But more female to male, I would say. I don't treat male to female so much, but female to male. And then you would just treat with probably 300 to 400 of testosterone, but inhibit estradiol. It's not, I don't treat that in practice.
Que ella no tiene en la práctica ese tipo de pacientes, que ha tratado alguna de mujer a hombre, pero no de hombre a mujer, y que probablemente 300 a 400 miligramos es una dosis que funciona, pero que no tiene ese tipo de pacientes. Thank you.
Está bien, está bien.
Okay.
Okay.
Yo tengo una pregunta para la doctora Rebecca. I've got another question for Rebecca. You mentioned, lo voy a decir en español, Spanish first. Mencionó, doctora, que está usted trabajando con el testosole y testosole con testosterona. Could you please tell us something about your experience or your vision? What is this testosole can offer to our patients?
Oh, gracias. Testosole is a combination implant with testosterone and anastrozole. We formally applied to the FDA for it. My vision, what I see is to treat patients with metastatic breast cancer with testosterone with an aromatase inhibitor for quality of life and disease control. So my vision is to make it worldwide, to help all women,
Excelente. Ella dice que ella presentó un trabajo para aprobación en FDA de la combinación directa entre testosterona con anastrozol y le llama testosol. Bueno, y eso es, su visión es poder ayudar a más gente en el mundo con este tratamiento y que la FDA apruebe. Thank you very much, Rebecca. El mundo, I know, the world.
Ok. Eli, ¿vos tenés alguna otra pregunta? Adrián, vos tenés para Barry, ¿no?
Sí, para el doctor, for Dr. Barry Sears. Thank you so much again, Barry. I always enjoy and I always keep on learning when I have the opportunity to listen to you because I am in the same tune. I'm going to say it in Spanish first. Thank you very much, Rebecca. El mundo, I know, the world. Sabiendo, sí, para el doctor Barry Sears, hay un eco ahí de alguien que tiene un micrófono. Sabiendo que la inflamación crónica es el... ¿Se puede apagar ese... Hay un micrófono ahí de Fernando. Un Fernando está con micrófono encendido aquí. Ahí está. Sabiendo que la inflamación crónica es lo que está detrás del deterioro de la enfermedad, del escenario de la dolencia, ¿qué experiencia nos puedes contar? I'm going to say it in English also. Entre inflamación crónica y COVID-19, knowing that chronic inflammation is the Lex Luthor behind the deterioration progress and the aging process. Could you please tell us something about your experience, what you have seen, what you have had the possibility to test between chronic inflammation and COVID-19?
There are some very, very interesting aspects. In terms of COVID-19, the complications come from a cytokine storm. And as I tried to put forward in the lecture, one of the best aspects of reducing a cytokine storm is activation of AMPK that turns off nuclear factor kappa B. Now, data has shown...
Let me translate this initial. Él dice que claramente esta tormenta de citoquinas que se produce en el COVID-19 tiene un impacto negativo y que la clave es en activar el AMPK. Yes.
In preliminary studies we've done at the University of Miami Medical School, that when a person goes on ventilation, their levels of arachidonic acid EPA becomes exceptionally elevated. We also have preliminary data of individuals who basically were hospitalized and on ventilation, that those who survived had a much lower ratio of arachidonic acid to EPA. The cutoff we used was 15. If the levels were a ratio of arachidonic acid to EPA were greater than 15, they had 4 times the mortality rate as those who were less than 15.
Okay, I'm going to translate this. Él dice que tomaron los niveles, la relación entre ácido araquidónico y EPA como para medir la inflamación, y tomaron como el umbral de 15 en pacientes que estaban internados, algunos ventilados, y que cuando esta relación era superior a 15, la mortalidad aumentó 4 veces. Okay.
And so we can begin to look at using the omega-3 fatty acids as one dietary tool, but also along with calorie restriction and polyphenols as a 3-pronged approach to reduce cytokine levels. And as you reduce the cytokine levels, the intensity of the complications drops dramatically.
Él dice que combinaron omega 3 en dosis elevadas con polifenoles y restricción calórica y que lograron dramáticamente bajar la mortalidad, mejorar y promover una buena mejoría de estos pacientes solo resolviendo la inflamación.
But what you want to be doing is starting the program before you get COVID-19.
That's right. Absolutely. Lo que dice, claro, habría que empezar el programa de medir su inflamación antes de tener el COVID-19. That's what I always say, this is our biological field, nuestro terreno biológico. Realmente es lo que la medicina tristemente no mide, y this is what doctors unfortunately are not educated to measure. Thank you so much, Barry.
Cual, ¿no? Tal cual. Hay que abrir un poco el panorama y abrir la cabeza, ¿no? Los médicos te lo enseñan en la facultad, Adrián, tal cual, lo que vos decís siempre en tus cursos de longevidad saludable, ¿no? En tu diplomado, decís eso, la verdad. Bueno, acá tengo una pregunta para Barry. Preguntan, ¿el omega en qué condiciones se debe suspender?
Pregunta para, question for Barry Sears, el omega. Omega-3, is there any situation that you consider that you have to discontinue the treatment or interrupt the treatment for any reason?
Only if the ratio of arachidonic acid to EPA dropped below about 1. Once it drops below 1, you might see a slight increase in bleeding.
Solamente si el nivel, la relación de ácido araquidónico y ácido ecosaminopentoico baja de 1. Si no, no, porque justamente la idea es esa. I'm going to say something in Spanish to explain the audience. Tradicionalmente, el ser humano, con una alimentación de puro paisaje y no góndola, solía tener una relación entre omega 3, omega 6, ácido linoleico, linolénico, 1 a 1. Uno es inflamatorio, el otro es antiinflamatorio. Hoy, consecuencia de nuestra alimentación de góndola, estamos 15 a 1, 20 a 1, 25 a 1, 30 a 1, y estamos andando por la vida como si nada. Entonces, bueno, estamos en un escenario de deterioro. I have just explained that the relationship between omega-3 and omega-6 has changed dramatically since Paleolithic era until now.
That is correct. And this is why that the certain populations, such as the Japanese, have an average ratio of arachidonic acid EPA of about 1.6. And these are the longest lived individuals in the world today.
Él dice que por eso hay algunas culturas, como los japoneses, que por su alimentación tienen un ratio muy equilibrado, y por eso son, no por algo, la gente que más esperanza de vida tiene en el planeta. Wow, amazing, amazing. Thank you so much.
Absolutamente, absolutamente. Eli, ¿vos tenés preguntas? Yo tengo acá. ¿Vos tenés alguna?
Sí, tengo una última pregunta para la doctora Glaser, pero antes quiero felicitar al doctor Barry Sears. Comparto ampliamente, y también lo que dice el doctor Gaspar, es increíble a veces la alimentación, con ese cambio de hábitos, y esta concientización es muy interesante. Felicitaciones, doctor. Una última pregunta.
Que el alimento sea tu medicina. Eli, perdón, yo digo, cerrando lo que vos decís, que el alimento sea tu medicina, ¿no? Ya lo decía Hipócrates. Ok,
y,
sí,
bueno,
sí, adelante, Eli.
Me hacen varios por privado. Pregunta a la doctora Glaser, bueno, dosis que tiene que ver, calculo siempre con el peso, ¿no es cierto? Dosis, proporción de entre testosterona y anastrozol o inhibidores de la aromatasa y el recambio. Esa pregunta concreta.
And there is a question from the audience about the doses.
Dosing.
Yeah, doses, yeah.
So what was the question?
Which is the appropriate doses in the combination of testosterone with anastrozole, for example? If I used, let's say, 100 milligrams of testosterone, how much anastrozole would I use with 100 milligrams? I think that is the question.
Bueno pregunta. It depends. It depends if they're breast cancer on the stage of disease. It depends.
Depende del estadio del cáncer.
Yeah, breast cancer, stage of disease, body fat. You know, how much body fat, how much aromatase.
Porcentaje de grasa corporal, el estadio del cáncer, que no es lo mismo, va a depender de todo eso.
But for metastatic disease, you want, if you use 180 milligrams of testosterone, you want at least 12 milligrams of anastrozole for metastatic disease, because that is active disease, or a tumor in the breast, or an active tumor. The ratio of anastrozole is higher, mucho.
Si usas en un cáncer metastásico, por ejemplo, en un cáncer metastásico, 180 miligramos de testosterona, ella lo recomienda con 12 miligramos de anastrozol, o sea, va subiendo la dosis de anastrozol. Porque es muy...
But for stage 1, stage 1, or DCIS, treated disease, you might only need 4 milligrams of anastrozole. So it depends.
4 miligramos. 4 miligramos para un estadio 1, que va a depender del estadio de la enfermedad, del porcentaje de grasa corporal de la paciente. How often do you recommend to replace, to insert another pellet?
12 weeks.
12 weeks. 3 semanas. 12 semanas. 12 weeks. 3 meses. 12 semanas.
¿Pacientes sanas?
In patients without breast cancer.
Oh, okay. In a patient without breast cancer, it's based on symptoms. Premenopausal women, 4 or 8 milligrams of anastrozole. Do you know what I mean? Testosterone is weight-based, so it depends on symptoms. So it depends on the patient. 4 or 8 milligrams, and testosterone based on weight.
And every 3 to 4 months too?
3 months.
3 months.
12, they'll say weeks.
Very good. Excellent.
I try. Be Spanish.
Very good. You're improving your Spanish. Nice.
Gracias.
I love that.
4, 8.
Tú eres muy simpática.
Well, this is a real international webinar. We're at different countries.
Yes. Adrián, me parece, Eli, ¿tenés alguna otra pregunta en el chat?
No, esa es yo resumí un par de preguntitas que teníamos. No sé si
bueno,
hay otra más.
Tengo una pregunta de la doctora Cristina Toa, y ya es la última. La osteoporosis, ¿podría contraindicar el uso del inhibidor de la aromatasa o lo contrarresta la testosterona? La doctora Cristina Toa pregunta.
If you have a patient suffering from osteoporosis, could that be a contraindication for the use of the aromatase inhibitor, or the testosterone should counteract the effect?
C, E, C. Yes and yes.
Okay.
If it's a breast cancer patient with osteoporosis and they had stage 3 or 4 disease, I would still use a little bit, un poquito aromatase inhibitor, okay? And monitor estradiol. But if it's not a breast cancer patient, then testosterone, solamente testosterone, no aromatase inhibitor. But breast cancer, depending on disease and length from diagnosis, you know, the time from diagnosis, you could treat with testosterone alone, but the testosterone overcomes a small dose of aromatase inhibitor. So it depends on the patient.
Depende de la paciente, pero que siempre en las concentraciones que usamos, la testosterona va a superar con creces el efecto de la anastrozol, así que no hay problemas. I have one more question for Dr. Barry Sears. After listening to you, there are a lot of doctors for sure in Argentina that would like to learn more and more from you, from the La Dieta de la Zona. Is there any contact you can share with us, with our society? Because we have a lot of patients suffering from inflammation, and we would like to know how to deal with them.
Yes, we actually have a group we work with very closely in Argentina, and they have really a world-class laboratory to do that type of testing. And they are, their company's name is Zone Diet Argentina.
Zone Diet Argentina. So we can find it through internet.
Yes.
Okay, thank you so much. So, si los que quieran progresar en esto de la inflamación mínima persistente y la dieta de la zona para beneficiarse uno mismo, primero, por supuesto, porque uno debe ser gerente primero de su salud para después poder gerenciar la de los demás. Eso es lo que yo siempre digo en el diplomado. Bueno, hay que poner ahí la dieta de la zona.com, ahí se los recomiendo, vale la pena. Thank you so much, doctor.
Thank you.
Me quedó una para el doctor Sears. ¿Puede
One
ser?
more question for, sí, yes.
Pregunta acá con pacientes, ¿cuál es la dosis de omega 3 que se debería administrar? La dosis de omega 3.
Is there any special doses of omega 3 you should recommend to everybody?
Again, as I said in the lecture, it depends. And your degree of illness and where the illness is located gives you a good starting dose. So for most individuals, I would recommend starting at about a minimum of 2.5 grams, but probably closer to 5. And then depending on the actually the blood, you can now titrate what's the right level needed for your particular condition. So it allows you to personalize it to the individual.
Que tiene que ser personalizado, va a depender del caso, obviamente, de lo que estemos tratando. Claramente es así, no es lo mismo un paciente que está dismetabólico con insulinas elevadas que un paciente que hace ejercicio y es delgado. Wow, amazing webinar. What else can I say? I'm so happy. Gracias, muchas gracias.
Bueno, muchísimas gracias, Rebecca. Thank you very much, Rebecca. Thank you very much, Barry.
Wait a minute. I would like to take a picture from the.
Okay. Pero vamos a hacer una captura de pantalla.
Dale, háganla.
Se los voy a mandar a todos. Muchas gracias, querido Adrián. Muchas gracias, querida Eli. Muchas gracias a todos y los convocamos mañana sábado para la presentación de las guías recomendaciones de la Asociación Argentina de Menopausia y Andropausia. Muchísimas gracias y hasta mañana. Gracias.
Thank you, bye bye. Thank you, chao, chao, bye bye.
Gracias, doctora Nigro. Muchas gracias, doctora Nigro. Excelente. Chao, chao. Gracias.